Good afternoon. My name is Michelle Pineda. I'm an OMIC risk manager. Today we're going to be speaking to you via a webinar on healthcare cybersecurity and give you an update on EHR risks. I am joined by Susan Doucette, who is the Director Program Underwriting for Tokio Marine. Good afternoon, Susan.
Hello, Michelle. Thank you for inviting me.
Thank you for joining us. Briefly, I'm going to go over the agenda today. Susan's going to talk a little bit about cyber landscape. Then she's going to talk about cyber claims trends, give you some claims scenarios, and then finally some best practices. I'm going to give an update on EHR risks at OMIC. Typically, we do have Q&A, but we aren't going to have Q&A today because this is a recorded webinar. With that, I'm going to turn it over to Susan.
Thank you, Michelle. We all use the internet every day, but have you ever thought about what lies beneath the surface of the internet? That would be the dark web, which is quite simply a black market for cyber criminals to buy and sell information. And some of the information at risk and the types of data being sold are health information, bank account credentials, credit card numbers, and social security numbers. And just like everything else, cyber breaches are trending. And some of the most common types of breaches are before and after pictures, employee carelessness or negligence, employees in social media, ransomware, rogue employees, phishing schemes, lost and stolen devices, and business associate breaches. In 2019, the Identity Theft Resource Center, or the ITRC, documented 1,473 breaches. That's a 17% increase over 2018. And as you can see from this chart, the healthcare industry had the second highest incidence of data breaches. Here are the most common causes of loss by rank for healthcare policyholders. For the second year in a row, employee negligence tops the list for causes of loss among healthcare policyholders, with ransomware and insider threats continuing to plague physicians, medical groups, and other healthcare facilities. In 2019, cybercrime claims in the healthcare segment saw a whopping 254% increase over 2018. By far, the most expensive components of any breach were legal and IT forensics expenses in 2019. We get asked a lot about how much coverage a policyholder should have. And there's no way to quantify that specifically, but we look at the average cost per record for notification expenses ranges from about $10 to $30 per record. This cost specifically accounts for hard costs. So this includes notification expenses and related credit monitoring expenses. With a clear understanding of the number of records that you have stored, you can run estimates of the cost to respond to a data breach. It's a simple calculation. You take the number of records times $20, which would equal the estimated cost of responding to the breach. So if you have 10,000 records times $20, that would be $200,000 an estimated cost of responding to the breach. This estimate is meant to be very rough and doesn't include the costs that come from lawsuits, regulatory fines and penalties, or lost revenue due to damaged reputation. So you can't rely on this 100%, but it's a good benchmark for notification expenses. Ponemon's 2019 report showed that the cost of a data breach is about $150 per record. Generally speaking, the reason why Ponemon's numbers are high is that they account for IT, legal, public relations, and expenses related to business interruption. They also factor in lost business as related to reputation harm from the breach. So taking the same example of 10,000 records, this would mean 10,000 records times 150 per record would equal 1.5 million. So using 150 per record is probably a good rule of thumb. One of the most common misconceptions that we see on the part of small practices is thinking that they really don't have an exposure. Just because you're a small practice doesn't mean you don't have an exposure. Most often, small practices are considered the low-hanging fruit for cyber hackers. They are literally banking on the fact that a small practice will not have the cybersecurity resources that larger medical groups have. If you have an IT team, just because you have an IT team doesn't mean your business isn't still at risk. After all, Anthem, Equifax, Facebook, and Capital One, they all have IT teams, and they all got breached. And just because your records may be stored with a third-party vendor also doesn't mean you don't have an exposure. What if your third-party vendor has a breach? You could be held liable for any personal health information that's been exposed as a result of their breach. Let's just take a look at a few claim scenarios that illustrate what cyber insurance actually covers. We'll start with the multimedia. In this scenario, a dermatology center uses before and after pictures of patients on their website with their consent under the condition of anonymity. When the photos are posted online, meta tags included the patient's last name, and as a result of that, show up under searches of their names. A few of the patients sued the clinic for unauthorized use of their likenesses. And as I mentioned earlier, before and after pictures are one of the most common causes of cyber breaches. Personally identifiable information, or PII, stored on meta tags and photos may not be visible to the eye, but it can show up on Google searches of someone's name. Our next scenario is security and privacy liability. In this scenario, an iPad is issued to a medical group employee and it goes missing. The iPad contained confidential records containing personally identifiable information and personal health information of over 1,000 patients. The group notified parties affected by the breach and offered 12 months of credit monitoring. As a result of the incident, the group was sued by several of the affected patients for failure to safeguard their confidential information. Physical theft of mobile devices can happen to anyone, anytime, which would explain why it's one of the top 3 most common causes of cyber claims. Next. In our next scenario for cyber extortion, we have a 5-physician practice that had its network breached when an office manager opened an email attachment that contained the CryptoLocker virus. The virus encrypted patient files stored on their servers, and the perpetrator threatened to delete the files unless a ransom was paid. Legal counsel in IT forensics determined the threat to be credible and recommended the ransom be paid so that further exposure or loss could be assessed. Cyber insurance paid for the legal and IT forensic expenses. Most people think that they should not pay ransom in this situation. However, it's generally recommended that you do because it's your best chance to recover stolen data. Keep in mind, in this scenario, cyber criminals are after the money, not the data. If criminals never returned the data after a ransom was paid, nobody would pay it and the criminals would be out of business. This is a cyber crime scenario. In this scenario, a physician's office manager receives an email from the physician who is out of town instructing her to wire $39,500 to him. The office manager wired the funds, and later when the physician called to check in, the office manager asked if he had received the funds. The physician then told her he'd never asked for any funds to be wired. The office manager had been tricked by a hacker who created an email address nearly identical to the physician's email address. The physician then contacted the bank to have the funds reimbursed. When the bank tried to recall the transfer, the funds had already been withdrawn from the fraudulent account and the account had been closed. The bank did not reimburse the physician for the lost funds. Cyber insurance covered the financial loss of $39,500 resulting from the wire transfer fraud. We have seen a dramatic increase in cybercrime incidents since 2016. This is a very common claim scenario. Cyber criminals create almost identical email addresses, which at a quick glance appear to be legitimate, but if you look really closely, you'll see one letter or one character will be different. We're going to go over some best practices for both users and IT departments. In this situation, we have some best practices for the users. The first one would be do not open links or attachments that are in unsolicited emails. The second, verify authenticity of software before downloading anything from a website. The third, do not use the same password for all accounts and make sure that they're difficult to decipher. And finally, for the users, do not send unencrypted emails. Now on the IT department side, the first one would be use antivirus software and make sure to update it regularly. Second one would be ensure Windows users have the Enhanced Mitigation Experience Toolkit, or EMET, enabled to sandbox applications. The third would be backing up data regularly and ensuring backup copies are stored in a separate and secure location, not on the local area network. And then limit access to certain areas of your network to help control the spread of malware. Next would be setting limits on timing and strength or lack of strength for login credentials within your organization. And lastly, set up a separate employee and guest Wi-Fi network. Here are 5 steps to fighting ransomware and business email compromise that everyone can implement right away. The first one is enforcing two-factor authentication, or 2FA, for secure application access. You're probably familiar with 2FA. Some of you may have this implemented on your own bank accounts or on login credentials for various sites. You have a login ID, and then you also have a second layer of security, which is most commonly some sort of code that might be texted to your phone or emailed directly to you that somebody who might hack into the system would not be able to get. The second one is implementing online backups. As I mentioned before, backing up data is a critical component here, and do not store your backups on the same network as the original information. You want to store them separately. Deploy spam filtering and email configurations. There are plenty of software programs out there that will help basically sense spam email and send it directly to junk or just block it entirely. And those are widely available and can be downloaded and implemented immediately. Installing next generation antivirus behavior-based protection. Again, this is another layer that this type of software, when downloaded into your system, basically runs 24/7 looking for various types of vulnerabilities within the system. And then lastly, conducting employee anti-phishing training. This is something that I also can't stress enough. Employee training is critical because more often than not, a lot of viruses and ransomware things that come through your system come through emails and somebody clicking on something. Next slide, please. Firewalls are also an excellent first step in cybersecurity. Firewall network security is a system designed to prevent unauthorized access to or from a network. Firewalls can be hardware, software, or a combination of both. Employee training, as I mentioned before, is a critical component of risk management. Cybersecurity procedures should be in place for things like email policies, information and mobile device and physical security, IT document management, and patch testing. These are just to name a few. As you can see on the screen, there are all sorts of training resources available, and OMIC insurers have access to many of these risk management resources through the OMIC website under the Cyber Liability link. Encryption is also a very effective way to achieve data security. To read an encrypted file, you have to have access to a secret key or password that enables you to decrypt it. Any information, especially health information, being transmitted electronically should always be encrypted. And lastly, as I mentioned before, the OMIC risk management site. This site is available to all OMIC insurers. They have access to the site through the OMIC website, and the risk management website has a number of resources available. There are employee training programs. You have access to expert cyber advice through the ePlace hotline, and the number is posted on the website. You have the online training courses, training coordinators, and support services available to you, again, through the online ePlace helpline. And then you also have webinars, pre-recorded webinars, email newsletters, cyber alerts, and state-by-state regulatory information and updates. These are just a few of the resources available to all OMIC insureds through the OMIC website. I'm going to turn it back over to Michelle for the update on EHR risks.
Thank you so much, Susan. This is so relevant for today as we're all working from home and doing the best we can during COVID. So I think that the insureds will find this extremely helpful. If anybody has any questions about how to log into the protected site, please just give us a call on the hotline or email us at riskmanagement@omic.com, and we'll make sure to help you get onto the site. Now I'm going to do an update on electronic healthcare record risks. I decided to divide this up into system and design issues and user issues. I've been reading a lot of statistics lately on, percentages, and it really is about 50-50, give or take a few percentage points of the issues that are coming up in lawsuits. And when I say system design issues and user issues, what does that mean really? Well, if it's a system or a design issue, it's the software basically. And if you have a good vendor and your vendor provides updates on your software, or they're available on the helpline, and you're having issues with any of some of the things I've listed here, the auto-populate button, the templates that are not for ophthalmology, lack of routing of data to appropriate place, you should give your vendor a call and tell them what the issues are and let them know that it's a problem for you, because oftentimes there are some workarounds for this. User issues really go more to training, something that Susan talked about a little bit. Incorrect information being entered, the use of copy and paste, incorrect drop-down choices, system alert issues, fatigue, conversion from paper records to an electronic system, and no signature on a record. So as we go through this, think about, where you might be having more problems with your own systems. Today, we're going to talk about how EHRs work into a malpractice claim or lawsuit. But EHRs also are popping up regarding HIPAA issues, billing fraud by insurers, claims of billing fraud by insurers. And then there's the question of who owns the health data, and of course, what Susan was talking about, cybersecurity. We hear, I present this on the road when I go to meetings, and I hear a lot about the frustration that doctors have with working with an iPad or a computer, and how they don't have the same rapport with their patients that they used to. There are some things you can do about that. You can use a scribe, you can use an iPad, and you can actually allow the patient to look at the iPad so they can see what you are doing, and you make them part of the process. I think patient rapport is super important and reduces the chance of a lawsuit. The role of the medical record in a claim or a lawsuit, well, it's really exhibit one. It's the key to why you thought about doing what you were going to do when you were treating this patient. It conveys your thoughts and it has your plan of care. So you want to get it right the first time. OMIC has only seen a few cases closed where the electronic healthcare record played a major role in triggering a lawsuit. But there is sort of a steady flow of issues that are coming up. It's typically not the issue, but it can make good care look bad when the system is auto-populating with information that's not correct or contradicts another part of the medical record. I'm going to talk to you about this first case. It's a 12-year-old male who had a history of being hit with a xylophone mallet at school. School nurse called the mother, and the child was taken to urgent care. The initial exam could not see the doctor's white jacket, so the child was referred to the ER at Children's Hospital. The ER evaluation following the urgent care was complaints of nausea, significant pain, visual acuity, hand motion, contusion, right upper lid, laceration, right lower lid, pupil fixed, dilated, non-reactive. The iris described as reddish brown versus soft brown on the other eye. So the ER assessment is a hyphema with iritis. Our insured is the doctor that's on call. So the ER physician calls our doctor, and our doctor over the phone prescribes medication and asks if the child will follow up at his office the next day. And there is a note that the insured did not come into the ER to see the patient. Well, at 5:30 in the morning on Friday, the child woke up with eye pain and was taken back to the ER by the mother. No progression of the hyphema on slit lamp exam. There's no hyphema identified. Headache, nausea, consistent with a history of migraines. Mother was given the drops that she was unable to find at the pharmacy. So our insured's EHR note, this is follow-up after the visit at 5:30. So the child does come to the doctor's office, and the insured notes a history as unremarkable, visual acuity 2400, normal findings except cell and flare, optic disc normal, retina flat, no holes or tears. Diagnosis was traumatic iritis. Treatment, no change in plan. Continue with the medication, the drops. Follow up on Monday. So there's no pressure recorded by anyone so far. I think it's important to note that the doctor was having a baby shower event in the afternoon for one of his favorite techs, and this was also occurring. It was a Friday, at the same time that he also had this child come in for a visit. So 11:30 a.m. on Sunday, child tells the mother he can't see out of the right eye. Mom calls our insured, but she's referred to a doctor on call. So you can imagine the frustration. Urgent care, ER, to the doctor who was on call for the ER, and now calls again on Sunday and gets a different doctor. That doctor, who is not our insured, elicits a history of sickle cell trait and tells the mother to bring the patient in ASAP. So it's not looking very good. No light perception. Here we go. We finally have a pressure reading, at least in the medical record, and it's 46. The pupils fixed. No view of the posterior pole. Performs therapeutic paracentesis. Brings the pressure down to 6. And again, prescribes more medication. On Monday, post-paracentesis exam with a new doctor who was on call on Sunday, which is not our insured. Visual acuity, questionable, light perception, pressure 24. Unfortunately, there was a central retinal artery occlusion. It just gets worse from here. Unfortunately, there's a retina evaluation, and the diagnosis is a central retinal artery occlusion secondary to sickle cell disease and sludging of the blood vessels. The family sued when the child ended up with light perception, hand motion vision. So what are the standard of care issues? It was mentioned that the insured should have come to see the patient that Thursday when the ER called, mostly because you can't rely on the skill level of the ER MD at that time. Insured should have asked about sickle cell, maybe full ophthalmic evaluation to rule out a globe rupture, and the insured's exam, which is really where the problem was boilerplate. And the insured testified in deposition about the baby shower that was going on in his office, and he didn't finish the note. And it had populated with information that was not correct. So the EHR issues. So the system populated with normal findings. That's a system issue. It also is a training issue because you need to know what the amount of time is before your system populates. Intended to finish a note and enter abnormal findings. Clinic got very busy. This is a user issue. And never signed the note. This is a user issue. The damages were light perception, hand motion, right eye for a 12-year-old. This case settled in mediation for $380,000. The next case is a drop-down menu medication error. This is a 60-year-old who called complaining of a sore eye post-shampoo, advised to treat with tears and follow up in a couple of days with the optometrist. The gentleman comes in 2 days later to see the optometrist, complains of blurry right eye, visual acuity, count fingers. He's diagnosed with a central corneal ulcer. The treatment is Zymaxid Q5, 5 minutes for 30 minutes. Then Q1 while awake, and Tobrex, alternating with Zymaxid. The scribe actually ordered Tobrex, which is a steroid, instead of Tobrex. I'm told that they are right next to each other in the drop-down menu. The tech thought that he was ordering a generic version of Tobrex. The patient continues to come in, and it's just a slow healing ulcer. There's no culture done. The patient is told to maintain the medications, and the doctor just notes a slow healing ulcer. Now we're about 20 days later, felt the medication, the drops contributed to toxicity, decreases some of the medication. Patient keeps coming back in, tapering off some of the other medication. Finally, 10/6, there's a culture ordered. And unfortunately, on the 11th, which is exactly 6 weeks later, a hypopion is noted. A culture is negative for bacteria and fungus. The medication error is discovered, and it's discovered because someone in the office, when scheduling the appointment, had asked the patient to bring all of their medications in with them so they can review them with the doctor. So the patient's referred to a cornea specialist, possibly a late referral, recultured vitreous tap, medication. On the 13th, increase IOP, hypertensive meds added. Can it get any worse? Unfortunately, yes, it does. The ulcer heals, but the patient requires a corneal transplant, and that didn't get better, ultimately required an enucleation of the eye. OMIC reviewed this case internally. The Tobrex error wasn't recognized for 6 weeks. That's a user error. Ulcer not cultured for 5 weeks, and there's a failure to refer in a timely manner. The percentage chance of a defense verdict was about 5%. So this case was settled for $750,000. One of the reasons for the high settlement is that this gentleman was a CEO of his own company, and he had significant wage loss. Some of the takeaways: rapport is still very important. Look at the patient, optimize the angle of the screen, share the information on the electronic healthcare, on the iPad, on the computer, share the screen with the patient, use a tablet, use a scribe. While charting best done same day, bigger priority is making sure it's done correctly the first time within a reasonable time frame. And we understand that it's very difficult to get the records all done the same day. And unfortunately, with the first case, the patient was seen on a Friday and everything happened over the weekend. And by Monday, we advised the doctor not to make any changes to the medical record because we didn't want there to be any question about the integrity of the record. Avoid common documentation errors, copy and paste, copy forward, cloning. These are user issues and use of normal defaults, system issues. If those are a problem, call your vendor, really, and see if they're going to make any changes in the next software update, or if it's possible to turn something off if it's really causing a lot of havoc in your office. Failing to update meds, that is a user issue. Insertion of macros, system issue. Wrong choice and pick list, that of course is a training issue. If you are having issues like this, best to sit down and figure out why, and try to nip that in the bud as quickly as possible. Information in one part of the record contradicts another. At the end of an exam, review the data, sign the note, and lock the note. That's in the control of the user. Know your signature requirements, and also know how to enter amendments after the fact. OMIC always recommends that if you make any changes to your medical record, you actually date it with the date you're making the change. You don't go back into the record on the date where the patient was seen. You actually take, let's say it was today, you use today's date and you say amending the record from previous date and indicate that date, and then make your change. Each provider should know what the records look like when printed, and it's always a good idea to have a designated and knowledgeable custodian of records. What I mean by that is, it's interesting, I got a phone call yesterday on our hotline just exactly about this. An office had released a copy of medical records to a patient who was unhappy. And because the office had been so busy with COVID and they had lost one physician, they were down one physician, they were behind in all their documentation, and the record hadn't been closed out. And so the patient was given a copy of her records, but it didn't include the most recent visit. So we spent a great deal of time trying to figure out how we're going to remedy that. The record had to be closed, and the patient had already called saying there was missing information and was very unhappy. So this is why it is a good idea to have a designated custodian of records. So this will conclude the EHR portion. I want to thank you again for joining us. If you have any questions of Susan or myself, just email riskmanagement@omic.com and I'll make sure that any messages get to Susan. Susan, I want to thank you again. Your presentation was excellent. I always enjoy presenting with you, and I look forward to doing it again sometime soon.
Thank you, Michelle. I enjoy presenting with you as well.
This will conclude our presentation.